Hi, Lawrence LeBrocq, managing partner of Garces, Grabler, and LeBrocq. And today we have Dr. Nirav Shah. He's a board-certified neurosurgeon with Princeton Brain, Spine, and Orthopedics. They have offices throughout New Jersey. And it's our pleasure to have one of the top neurosurgeons in the country here with us today. How are you, Dr. Shah?
Hello, how are you? I'm really happy to be here. Thank you.
It's our pleasure to have you here. Could you just, for our audience's benefit, give us a little bit about your background and experience as a neurosurgeon?
Yes, hello, my name is Nirav Shah. I am a neurosurgeon, which essentially means I'm a brain surgeon, but also a spine surgeon. In order to be one of these, you can imagine it takes a lot of schooling. I'm a relatively local product. I went to medical school at Jefferson Medical College in Philadelphia. Upon graduating in 1999, I attended something called a residency, sort of extended training program to learn how to become a brain and spine surgeon. I did that at the University of Maryland for the next 6 years. Over that time frame, I did thousands of brain and spine operations, learning the various intricacies in that business. But as you can imagine, this is the practice of medicine. We don't learn everything in residency. And then once we get out of the residency, we have to submit 2 or 3 years of clinical data to become what we call board certified, where we take an exam, both written and oral, to establish that we have a true expertise in this field. And I was board certified in 2005, and then in 2009, and then subsequently in 2019.
And doctor, what does your clinical practice consist of now?
Yeah, so for me personally, I'm a brain and spine surgeon. That's what I love to do. Neuroscience is a real fascinating thing for me. I've always been interested in it since college, did a lot of research in it, hung out with a lot of other neurosurgeons. Honestly, I thought they were the coolest residents in medical school. They just seem to work hard and sometimes play hard. But ultimately, they did the right thing by the patient, and that's what really I wanted to invest in. And so every day I'm seeing patients who have either a brain or spine condition, predominantly spine. I would say at this point in my practice, most of my work is relegated to the spine, although I still perform brain surgery. I see about 70 patients per week in my office. 80% of them have neck and back complaints that I have to figure out whether or not surgery is appropriate. The rest have brain complaints. And then I have on-call responsibilities. My practice is the largest neurosurgery group in central New Jersey. Collectively, we cover all of the major hospital systems 24 hours, 7 days a week, including myself. I'm on call once a week at these hospitals. So on a monthly basis, I may have to come in and perform an emergency brain and spine operation.
Tell us, what would cause an emergency brain or spine operation? Let's start with the brain.
Trauma, injury. I see patients who have injuries while at home trying to fix their house versus someone who's in a high-speed car accident. I've had patients who are wide awake, and then I look at their scans and I don't know why. And I have patients who are in a coma, and I'm still trying to figure out why they're in that state. So it's a very unpredictable practice. It's an unpredictable medicine. And when we see trauma, we have to act pretty quickly, swiftly, and intelligently, but most importantly, communicate with the family.
Sure. Now let's talk a little bit about trauma. Let's just talk about your normal automobile collision. When somebody doesn't strike their head, the defense always states they couldn't possibly have a closed head injury or a brain injury because their head didn't strike anything. Do you want to explain why that is not accurate?
Yes, I respect anyone's opinion in regards to that, regardless of what side of the aisle they are on. But ultimately, when you do perform contemporaneous treatment, treatment that's current, cutting edge, when you're a team doctor, for example, from Monmouth University, like my practice is, or selected to become an affiliate with the Trenton Ironhawks, who are the hockey team that are going to be coming in. The reason they chose us is because we are on the cutting edge of this. And we realize you do not have to strike your head and you do not have to lose consciousness to actually have a concussion. What has to happen is that an acceleration and deceleration force has to be applied to the brain The brain is mobile inside your hard skull. And so much like a piece of Jello on a plate that gets shaken when you touch the table, the same thing can happen with the brain when sufficient forces are applied to it. That causes the brain to accelerate against the hard skull. And when it crashes against that hard skull, like an accordion, it tends to collapse and expand. And when it does that, it actually tears invisible to the naked eye cells in the brain tissue. And that can cause disruption of the brain tissue, disconnections, and something we call concussion.
All right, so there's different levels of concussion. Is that accurate?
Yes, again, doing this on a daily basis, we used to try to be rigid and grade it, mild, moderate, severe. Really, the more you do it, the more you realize no one really knows what that means. Ultimately, the standard now is that each case is a case-by-case basis. Some patients come in and they're not as severe on initial arrival, but over a period of time, their symptoms escalate. Whereas some people have severe symptoms on arrival. So again, it's very hard to grade these things because oftentimes they're graded on arrival or acutely, and we have to look at the total picture.
Right. Now, there are diagnostic testing other than a CAT scan, which used to be the gold standard. What is now the gold standard for brain testing to see if somebody has concussion or any sort of brain damage?
Yes, well, a CAT scan is a good initial study to look for bleeding in the brain. It's the gold standard for that. So in my trauma centers, we often get a CAT scan just to make sure there's no bleeding that I have to go in and drain out. Now, beyond that, an MRI is the next step, and that gives us better definition of the internal tissue. The brain is made up of two regions of cells. We call it the white matter and the gray matter. And when you look at a scan, you can actually see that one's more white, one's more gray. It's just based on some of the enzymes and the density of the cells. And it's the white matter area that tends to get disrupted in a concussion. That's what we call diffuse axonal injury. Diffuse meaning widespread, axonal meaning the axons, which are the tentacles of those nerves in the white matter. And then, of course, injury is injury. And when we suspect that, an even more sensitive scan is done called a diffuse tensor imaging scan. And what that does is it tracks water molecules and their movement inside the brain. When that movement is disrupted, that area tends to highlight, and we can surmise based on the mechanism of injury, based on the symptoms of the patient, based on our physical exam, that what we're seeing on that diffuse tensor imaging image is an actual brain injury.
And that's a fairly new test, isn't it?
Yes, it's not something that's widespreadly used, but it's often used when we have a high degree of suspicion for someone who has a significant brain injury that's not brain bleeding. That's not a skull fracture. That's something that we haven't seen anything on imaging yet, but they're still compromised. It's a very helpful study to help guide future care, such as neurobehavioral care, cognitive therapy, balance therapy, medication management, visual therapy. These things can be aided when we know what area of the brain is predominantly disrupted.
Now, would a DTI be useful in somebody that may be suffering from CTE, or can you only see CTE after a person passes?
Yes, what you're referring to is chronic traumatic encephalopathy. Chronic meaning long-standing, traumatic from multiple injuries. And then encephalopathy is another word for brain damage. When the cells have damage in the brain and the spinal cord, the reason we often get permanent injuries with a stroke or spinal cord damage is because those cells do not regenerate. Instead, they tear and they leak out vital enzymes. And those enzymes can collect like protein accumulating into plaques. And that's what leads to this CTE portion. And unless it builds up significantly, even on a DTI, you may not see that.
Right. That's very interesting. And I'm sure you're very familiar with the symptomology, being involved with Monmouth football program and now the new hockey team down in Trenton.
Yes, definitely. Concussions are something my practice, myself included, see frequently. We have in our own practice physical therapists that perform balance therapy, rehab doctors that provide medical management, even Botox therapy to help with headaches. We have pain management doing nerve blocks. So there's an integrated care that is often required in these types of injured patients.
Is there anything else you'd like to share with us about brain injuries and your treatment of brain injuries before we move down the body a little bit to the spine?
No, I think we've bored your audience enough. I find it interesting, though, and I could talk all day about it, but I think we can move on.
All right. And so you deal with a lot of trauma. You said about 80% of the trauma that you're dealing with is neck and back.
Yes, when we talk about injuries, not everyone comes in with brain injuries. To be honest with you, the neck and the lower back, cervical and the lumbar, those are areas that are like, you can imagine a pogo stick. Those are areas that have bendability to them. They're not fixed. They're not protected by anything like the brain is with the skull, or the thoracic spine, the mid-back with the rib cage. So if you get into a car accident, a lot of times the forces spread to the neck and the back because they're mobile segments.
Now you'll see cases where, or we'll see cases as well, where there's not a lot of damage to the vehicle or no damage to a vehicle, yet there's still a significant injury in the neck or back. How does that happen?
It can happen. I've seen it. And like I said earlier, when I do an emergency room consult, I'm often surprised sometimes how people survived a high energy impact and how they're so compromised when something isn't. So I've learned that the pictures do not speak 1,000 words necessarily. What we've learned is that we don't measure newtons. We're not, biomechanical experts. But as a physician, what we understand is that sufficient forces were applied to that patient at that particular time and that particular set of circumstances in that particular car that resulted in a sufficient energy transfer from the collision to the body of the patient that has resulted in marked symptoms. And again, they may not be prevalent as much initially, but as time goes on and you keep using those injured body parts, they can escalate after that.
Right. Now, as a neurosurgeon, you're usually not the first doctor somebody sees after a trauma, unless it's very severe.
That's correct. That's correct. I usually get most of the patients I see in my office are referrals from other doctors.
Right. And that's because they have significant injuries. So what types of injuries will be referred to you from a trauma, such as a fall, an automobile collision?
Yeah, anything from a bone injury, such as a fracture, maybe that went unnoticed on the initial emergency room evaluation and then was diagnosed by a pain management doctor, a rehab doctor, a chiropractor, therapist, and then referred along to me. That's more obvious. Then patients often will get an MRI. That MRI, after a period of time of not getting better with treatment, may show evidence of injury. That evidence can be something called a herniation. We call that a slipped disc. The disc is like a shock absorber between the bones in your spine. And it's in that area that the forces collect. And if sufficient force is applied, it can tear the disc and leak out that material and cause symptoms. We call that a herniation. Now, you can also get that with aging as well, to be fair. But in the case of an injury, that can also happen. And when that happens, certainly it's a permanent injury.
Well, you see the defense a lot of times in litigation. If they can't say the herniation's not there because it's showing up clearly on an MRI, they'll always argue it's degenerative. How can you tell that something is acute or new as opposed to degenerative in nature?
Well, as a doctor, we're no different than a detective. We're trying to put a puzzle piece together. So we cannot use one piece of information in order to make a conclusion. That's what we call clinical correlation. As a neurosurgeon, I rely on a number of factors to formulate an opinion. Those factors include the history of the patient. So it's important to interview them, put our hands on them through a physical exam to establish their symptoms, read some of the records, if they're before or after or both, from this accident, review the imaging, review any other testing like nerve testing or selective nerve blocks or what treatment was done, and then use my experience in training. Remember, I'm a surgeon. So where a lot of attorneys or other doctors might have said it's a degenerative problem, I've gone in on someone's body and actually seen a softer tissue herniation that proves it's more recent. It's not a degenerative issue. So I rely and lean on those types of factors to formulate that opinion. And again, we're not professing to say we know 100% certainty that this is from the injury. But when you factor in the history, the physical exam, the records, what was done to the patient, how they were doing leading up to the incident, how they were doing after the incident, the imaging, the nerve testing, your experience in training, you can come back to the MRI and say, hey, that's a herniation. Even though a radiologist might not say it's a herniation, even though another doctor in another specialty may not say it, or even in your own specialty, what we are looking at on an MRI cannot simply be looking at the MRI on its own. It needs to be coupled with the other factors. And when you put it all together, you can then surmise it's a herniation. You can use some aspects on the MRI to help you. For example, if there's a brighter signal within the herniation, whenever an MRI lights up, that indicates hydration, swelling. Well, what's inflammation? It's water accumulating. And so when that's brighter, you can surmise that there was a recent injury there. So again, we kind of put the puzzle pieces together. We don't know with 100% certainty that it is related to the accident. But when you put all of the evidence together, then we can surmise within a reasonable degree of medical probability and certainty that there is a causally related herniation.
So if somebody comes to you with a herniated disc, they've probably gone through pain management, maybe some epidurals to try to reduce the symptoms or alleviate the symptoms. But when they get to you, they're usually not responding to any of the physical therapy or the different modalities that they can attain with other types of doctors. So when they come to you, what is the determining factor as to whether or not you're going to recommend surgery?
Well, there are three factors that I utilize. Number one, do they have some findings on exam or some kind of objective evidence of why they're having pain? Now, they may not have weakness. They may not have sensory loss. They may have normal reflexes, but an MRI might show nerve compression from the herniation. That's objective. That means objective means something a patient has no control over. So if that's positive, that's one check mark. The second, have they gone through conservative treatment? What is that defined as? Any combination of therapy, home exercises, medication, injections, activity modification, work restrictions, anything like that. You don't have to go through all of those to get to me, but you should go through some of those unless it's an emergency. And then finally, and probably most importantly, quality of life. Is it affecting your day-to-day activities? Are you not able to do what you were doing before? Are you not able to enjoy your family? Are you not able to enjoy sports? Are you unable to work? These are the things that I'm asking a patient, and that's critical to determine if the risk is worth doing the surgery. And if you check mark all three of those, then I believe you are a surgical candidate.
All right, so now let's go into the different types of surgeries you perform, from the least invasive, or your technically most minimally invasive procedure, as to the most complex procedure with the longest time for recovery.
Well, the least invasive procedure I do is what we call a discectomy. What that means is a herniated disc is pinching a nerve, and what we'll go in and make an incision and try to remove that portion of the herniation. That's usually an outpatient procedure, can be performed in a surgery center setting, still under general anesthesia. You're put to sleep with a breathing tube, but you can go home on the same day. And the recovery is variable, but can often be in the 6 to 8 week time frame. Whereas the most complex thing that I do, aside from brain surgery, is spinal fusion surgery. So that means not only taking pressure off of the nerves, but inserting hardware to stabilize the spine. When you take away something from the body, you could cause instability. It's like Jenga, those Jenga board games. If you take away something, it falls apart. So you may have to put something back in. That's the judgment of the doctor. That's a spinal fusion when screws and rods or plates are applied. And then I do everything in the middle. In the middle, something called an artificial disc replacement has come about, where we make an incision, we remove the discs, but instead of putting a plastic spacer with bone and screws, rods, and plates, we actually put a synthetic ball and socket type device into the spine to replicate the motion of the spine, the motion of the disc. That's called an artificial disc replacement. It's newer technology. It's still investigational in terms of long-term data, but it has been highly effective, at least in the short term, in terms of getting people back on their feet quicker. It does not necessarily mean you don't need a spinal fusion. It's a good way to kick the can down the road, if you will.
Now, with the new disc replacements, you do not have to insert anything into the bone. How do they stay in place?
Yes, the bones are attached to one another by the disc. They're under pressure. Once we remove the disc, there's a hollow area between the vertebrae. We actually put pins in each vertebrae and then a crank that cranks them apart. We then are able to insert that artificial disc and then uncrank it so that the vertebrae collapse onto that disc, holding it into place.
Wow, it's amazing. So, doctor, what would require emergent surgery? You mentioned a brain bleed. What else would require emergent surgery? Somebody's in an automobile collision, they fell from heights, and they in the ER, oh shit, this person needs immediate surgery.
Well, a more recent thing that comes to mind in the last several weeks was a patient who had fallen as a result of a work-related injury in which they suffered a very large herniated disc between the fourth and fifth vertebrae in their neck. And it was pressing on the spinal cord, and they came in very weak. They could barely move their arms and legs. And that's something you got to get your butt out of bed. You got to get in there. You got to take that pressure off immediately. So that's what we call a spinal cord injury. And obviously a brain bleed is another opportunity to come in emergently. Spinal fractures, if they're causing a neurologic deficit, is another reason. Sometimes we can temporize things until the next day, but those are things that we tend to do right away.
And what's the importance of getting it immediately if somebody's suffering from quarter equina syndrome? Please explain what that is and why it's so important to get in right away.
The lower back is made up of a bunch of nerves that, if you were to take a cross-section of it, looks like a horse's tail. And that's what we call cauda equina, horse's tail for Latin. And each those nerves go into your lower extremities. There are some of them that supply sensation and function to your genitals, to your bladder, and to your anus. And so if you have a herniated disc that's pinching that area and it's causing a dysfunction in urine output, sensory loss in the groin area, your bowel incontinence, that's brand new. It's important to try to get to that within a reasonable time frame, at least within 3 days, ideally, but immediately as possible, because you want to cut your losses. You want to be able to stem the tide, if you will, and try to get as much reversibility as possible.
Right. And that's because, unlike other nerves in the body, the spinal cord does not regenerate.
Yes, exactly. So when you get a nerve damage, it often is unforgiving.
Now, we are partners with Eric LeGrand and the Rees Foundation in that fight against paralysis. Since you are a neurosurgeon, are they making any inroads in the fight against paralysis and trying to regenerate the nerves of the spinal cord?
Well, incidentally, I ran the New York Marathon twice as part of the Christopher Reeves Foundation, and his mother, generally speaking, when she was there, was a patient of one of my partners in the Princeton area, and so we're familiar with the organization. We haven't really participated because I've gotten older in the New York Marathon, but we definitely hold that near and dear to our hearts. It's good and bad. It's great because we're seeing a lot of research, a lot of promising research, but it's still bad. Practically speaking, when a patient comes into my emergency room with a frank spinal cord injury with paralysis, their prognosis remains extremely poor for a full recovery. It is what it is. We haven't figured it out yet, but the future is bright.
Good. Well, I'll give a little plug right here. This year, the Walk to Believe by Eric LeGrand and the Reeves Foundation is on September 24th at the Rutgers versus Howard game. So if you're free, please come and be our guest at the game. Bring your family, and you're more than welcome. We'll have the party deck rented out for after or during the game. So after the walk, we'll head over there. So, Doctor, please tell us, our audience, about your practice. I know you're the medical director of Princeton Brain, Spine, and Orthopedics. What do you cover? What do you take care of? And how should people get in touch with you if they are suffering an injury?
Well, we cover a wide geographic bandwidth within the state of New Jersey. We actually extend into Pennsylvania. We're from South Jersey, Mullica Hill area. We cover Inspira Health Networks all the way to Somerset, and east to Freehold, New Jersey, Monmouth County, west all the way to Flemington, New Jersey. So we cover a large swath of land. We cover the gamut of musculoskeletal injuries from all the way from the head to the foot. So a head injury, concussion care, neck injury or neck symptoms, lower back issues, knee, hips, joints, hand injuries. We cover it all. We have therapy options in central New Jersey as well. So we like to think of ourselves as an all-inclusive practice, providing what we think are cutting-edge care. We are proud of our partnership with local area colleges, high schools, professional sports teams, hospital affiliations. We're in really good standing in a lot of these places. So if you have the misfortune of having to go to an emergency room in central New Jersey, more likely than not, if it's a neurological condition, our practice will service you.
Dr. Shah, it's always a pleasure. I look forward to the home and home games between the Giants and your Eagles, and hopefully we'll get together at one of the Trenton hockey games once that season starts up in late October.
You got it, man. Thank you for the opportunity. Thank you, everyone, for listening. And if anything we can do for you, please. The title speaks for itself. This is a good thing that you're doing, raising awareness.
I appreciate your time, Doc. Always a pleasure. Take care, buddy.
Take care.